Welcome all to the new session of vertical integration. So this time we have chosen a specific topic that has got a lot of importance in the current status. We have chosen peripheral vascular occlusive disease, or you can call it as peripheral arterial disease. So we have an panel available here. From to my right, Dr. Manish, Associate Professor of Radiology, and he's will be dealing with the investigation aspect. What are the therapeutic aspects of PVOD, and Dr. Akshara from the Department of Anatomy, Associate Professor. So, Madam will be enlightening us regarding the basic anatomy regarding peripheral vascular diseases, and we have Dr. Nandita, who is here again from Department of Pathology. So, ma'am, we are again very happy to have you here. Thank you, ma'am, to joining us, and Dr. Ajit, Assistant Professor from Department of General Surgery. So, with this in background, I will start with Madam. Because anatomy is the first thing that we always learned in our first year. So we'll start with Madam again. Ma'am, can you briefly describe the anatomical distribution of major peripheral arteries in the lower limb?
So the major distribution of lower limb is coming from femoral artery, which is the continuation of the external iliac artery. In addition to that, we also have the contribution from internal iliac artery, that is the obturator artery in the medial compartment, as well as in the posterior aspect. Gluteal region is also, gluteal arteries are also from the internal iliac artery. But peripherally, the major contribution is from femoral. So the femoral artery is continuing from the external iliac artery behind the inguinal ligament. It entered the femoral triangle. So this artery is between mid-inguinal point. We can locate it between the anterior superior iliac spine and the pubic tubercle. And this artery is superficial in the femoral triangle, and it is in the femoral sheath. And it is giving the important branches to your lower limb, like deep branches called profunda femoris, which is giving the lateral medial circumflex artery, as well as this perforators, which is supplying the thigh. And it is also giving the superficial branches like superficial epigastric, superficial circumflex iliac, and superficial external pudendal. And this artery will pass through this one adductor canal, that is on the medial aspect of your thigh, and it passes through opening in the adductor magnus. There is adductor hiatus, and then this artery enter the posterior aspect, that is, it is reaching your popliteal fossa. So then this artery is called as the popliteal artery, and then it reaches the popliteal fossa, and at the lower border of popliteus muscle, this artery divides into two, that is the anterior tibial and the posterior tibial artery. And this anterior tibial artery then enter into the anterior compartment. So there is an opening in the interosseous membrane which connect the tibia and the fibula. So it passes through the opening in the upper aspect, it enters the anterior compartment and supply the anterior compartment of your leg. And posteriorly through that, it is the posterior tibial artery, it is supplying the posterior compartment of your leg. And finally in the dorsum, this anterior tibial continue as the dorsalis pedis, that is responsible for the blood supply of the dorsum of the foot, as well as this posterior tibial artery is giving the plantar arteries, medial and lateral, that is responsible for the blood supply of the sole of your foot. So this is the brief idea of the distribution of the arteries in the
thank you, ma'am. Thank you, ma'am. And so the importance and the clinical significance, I think we can discuss in between. So whenever we comes in, when we have the clinical details, we'll have the applied aspects also. Coming to Nivedita, ma'am, and I'm really sorry that I pronounced it again as wrong as instead of Dr. Nivedita, I said Dr. Nandita. So Dr. Nivedita for you in front of you. Ma'am, can you briefly tell what are the primary histopathological changes observed in the arteries affected by peripheral artery disease? So you can use the mic.
So the hallmark feature of any peripheral occlusive disease would be the formation of an atheromatous plaque. They are commonly observed in areas where there is increased turbulence or non-laminar blood flow, usually in areas like posterior part of the abdominal aorta or ostia of the blood vessels or the places where the arteries branch. So these are the common locations where they are formed first. So atheromatous plaque has different components to it. You have cells such as smooth muscle cells and macrophages and T lymphocytes. that is the cellular component. Then you have matrix proteins, like extracellular matrix proteins like the proteoglycans. And as the atheromatous plaques age and evolve, they can have calcification. The grumous core is composed of cholesterol and cholesterol esters and the lipoproteins. So they can be a stable plaque or an unstable plaque, and it depends on how the plaque has evolved. So the composition can vary. A stable plaque will have a strong fibrous cap and shoulder composed of cellular elements. However, in an unstable plaque, it is the other way around. The cellularity is more than the fibrous area.
Okay, ma'am. Thank you, ma'am. Thank you. Dr. Ajit, can you just briefly describe the clinical features and the risk factors and etiology of why a PVOD or a PAD is happening?
Okay. We'll start with the etiology first, and then we will discuss the clinical features. The etiology, the main etiology, as Madam told, is atherosclerosis. Atherosclerosis is the main thing which is the main reason for PVOD, peripheral vascular obstructive disease. But for atherosclerosis to occur, there are multiple risk factors. For example, smoking is a risk factor, and diabetic is a very high risk factor for atherosclerosis again. So a patient with diabetes, even though the peripheral vascular disease in diabetes is multifactorial, the patient may present with atherosclerosis. And there are multiple, if the patient is a smoker, Burgess disease is other type of disease which occur in the medium sized vessels, where atherosclerosis usually affects the larger vessels of the aorta and aortoiliac vessels, and Burgess disease below that. And diabetes as such can present with arteriopathy, which can cause distal arteriopathies. It can cause. So all these things causes peripheral vascular disease. And the other thing is vasculitis. Vasculitis can also cause. There are multiple vasculitis which can cause the peripheral vascular obstructive disease. Next is the clinical features. The main clinical feature will be the intermittent claudication. The intermittent claudication is an crampy type of pain which occurs in the calf muscles or anywhere where there is a level, anatomic level, one level below where the obstruction is there. For example, the most common site for obstruction in the peripheral vascular diseases is the popliteal. So obviously the most common sign will be in the calf muscles, the intermittent claudication. The intermittent claudication usually occurs whenever the patient starts to walk. The patient develops pain in the calf muscles. It's a crampy type of, unlike venous pain. Here the pain will be severe because it's an ischemic pain, which is caused because of accumulation, anaerobic metabolism is occurring because of less blood supply in that area. So accumulation of metabolites will be there. So the pain is ischemic pain. It will be severe, but it's a crampy type of pain. And there are different stages in the intermittent claudications, which the mild intermittent claudication, when the patient starts to walk, he may feel some pain, but usually if the patient continues to walk, the pain is usually reversed because there is a compensatory mechanism in the blood vessels, peripheral blood vessels, where there is dilatation because of accumulation of the metabolites. There will be dilatation of the vessels, so all the metabolites may be washed away, so the pain will decrease. That's the mild type of intermittent claudications. Next is an moderate intermittent claudication. The pain will continue, but the severity of pain is not so much, so the patient usually does not stop. The pain usually will be there. And the severe type is unless and until the patient stops and takes rest, the pain will not reduce, and the pain severity also will be very high. So in intermittent claudication, there are multiple classifications. There can be Fontaine classification as well as Rutherford classification, which I told mild, moderate and severe. That comes in Rutherford classifications of the intermittent claudications. And etiology as well as clinical features. Yes, the clinical features in the chronic, the two things you have to identify is that if the peripheral vascular disease is acute or chronic, the clinical features differ based on that. If it's the main thing which differs in both is the presence of the collaterals. The presence of collaterals, so the severity of all the symptoms will be less when it comes to chronic disease because of the presence of collaterals, and the symptom development also will be very slow. The severity is less, and also it is over a long period of time. That is how you will know that it's an chronic peripheral vascular obstructive disease. If it's an acute, the main features will be severe pain will be there. As it's an ischemic disease, most of the ischemic pathology will have very severe pain. So here also severe pain will be there, and pallor will be there. That is the redness of the peripheries will not be there, so there will be a pallor. Next, paresthesia, that is altered sensations, paralysis. So again, because of the decreased blood supply to the nerves, the sensory as well as motor, both will be affected. So paralysis will be there, paresthesia will be there, and pallor and pain we already discussed. And the other thing which yes,
we have
pulselessness. Yes, sorry, there will be absence of pulse. That is the 5 P's which we say. Okay, the pulselessness which occur. And in chronic, the pulselessness may not be so acute, mainly because of the collateral. Sometimes the pulse will only be reduced. There will only be reduced pulse may be there. And the other features, the pallor also may not be so severe as in acute peripheral vascular obstructive disease. But sensory loss and motor loss are only seen more in acute diseases. So in chronic disease, the other things which you can see is loss of hair will be there, and muscle atrophy will be there. So in your inspection, in your clinical inspection, you can see that the patient will not have lot of hair there, and the skin will be dry, mainly because of reduced blood supply to the sebaceous glands as well as the sweat glands. So the skin will be dry. And the most important examination in this thing is the palpation of the peripheral pulses.
We will take it up to the next question.
Yes.
I think that the claudication pain, that is
Yes,
what the key
that's
clinical
the most
features
important
that
clinical
what you need
feature.
to
Yes.
highlight here. Maybe the most important clinical features that we all need to remember. Dr. Manish, can you just let me know what are the common investigations? So when we see a patient with peripheral artery disease, I'll give the mic to you. So what are the common radiological investigations that an undergraduate should know, and when to do these things?
Yes, as we have discussed now with our discussions, having a basic anatomy understanding, and then the most important thing is the history, followed by the clinical examination. Now, if we have the history and the clinical examination, then we know where to subject the patient to what examination. For example, now imaging wise, we have ultrasound, we have CT, we have MRI. But then of these, ultrasound would be the basic first line modality of investigation, wherein we would be based on the history and the clinical examination. For example, a patient has come, he's a smoker, and he's got clinical signs of claudications, and we are suspecting PVOD for him. So we need to know where is the exact site of obstruction. And depending upon that, then we subject him to ultrasound. But at the same time, if it is a young patient wherein some vasculitis is subjected or suspected, in that case, sometimes Doppler may not give you the answers for that. So then we'll have to, after doing a screening Doppler, we can get into either MRI or CT, where we are going to look into the soft tissue structures around or the vascular thickening, which might not be very much evident in a ultrasound. So in ultrasound, basically we subject the patient initially for ultrasound and Doppler, wherein we first do a B-scale mode imaging to find if there is any atheromatous plaques there, to see, as madam already said, that if it is a calcified chronic plaque, then the chance of that getting ruptured is less likely. So there is the same point with the carotids also. So that is one thing which we look, and then we do the Doppler. And then when we do the Doppler, we try to find out what is the flow pattern, whether it is a multiphasic flow, or is it a biphasic flow or a monophasic flow. Monophasic flow just means that there is some significant proximal obstruction, and from where we are getting that monophasic flow, that should be the point of obstruction, and we know that we have to intervene in that particular location.
Okay. Thank you. Thank you, Dr. Manish. Again, coming back to Madam. Ma'am, we discussed regarding the arterial supply of the lower limb. Can you just briefly go through the blood supply of the foot in specific? Because as we see a lot of trauma cases, that is what we are more interested in when we look into the emergency medicine consults. Can you just brief out?
Okay, that we already seen that at the lower border of popliteus, the popliteal artery is dividing into anterior tibial and posterior tibial artery. And among this anterior tibial artery, as it passes through an opening in the upper part of interosseous membrane, it reaches the anterior surface of your leg, and it is going to supply the anterior compartment of your leg.
Okay.
And in the upper part, it is deep, but coming to the lower aspect of your leg, it becomes superficial. Then it reaches, behind this inferior external retinaculum, it passes and it becomes dorsalis pedis artery.
Okay.
So that is midway between the two malleolus is the location that is medial to the tendon of extensor hallucis longus. So there you can palpate the dorsalis pedis artery.
Again, very landmark
Yeah.
where you need to palpate.
So that is midway between the two malleolus also, and this is one of the most important artery when regarding this disease also. That is artery that we are taking the pulse because it is more superficial and easy to detect. That pulse we can take very easily because it is overlying the tarsal bones there. So and this dorsalis pedis artery is going to supply. It is giving the medial lateral tarsal arteries. It is supplying the tarsal bones, and it is also supplying the dorsum of your foot. Okay. So it reaching the first intermetatarsal space. Then this artery is giving branch like lateral tarsal. It is giving arcuate arteries also. Arcuate artery is giving the metatarsal, that is a dorsal metatarsal, second, 3 and 4th digits. It is giving the dorsal metatarsal arteries, again divided into the digital arteries each, and supplying your dorsal aspect of your foot.
Okay.
And after that, this dorsalis pedis artery is passing between the two head of the dorsal interosseous muscle.
Okay.
It comes to the sole aspect.
Okay.
So there it is going to complete an arch with the plantar arch.
Okay.
So sole of the foot is mainly by this supplied by the deep aspect by this plantar arch.
Okay.
So what is this plantar arch is? The posterior tibial artery that is lying on the posterior aspect or the flexor compartment of your leg. It passes between the medial malleolus, and it is giving the medial plantar branch and the lateral plantar branch. So this lateral plantar branch, it is entering the sole of the foot, and it is giving the plantar branches there,
Okay.
digital branches. So that is how the sole is supplied, and this is completing with that of the continuation of the dorsalis pedis, the plantar aspect which is dipping into the interosseous muscle. It completes the plantar arch.
Okay.
So that is how the arterial supply of the foot it happens. So it is supplying the dorsal aspect is by the dorsalis pedis, and the other aspect, the interior of the sole, is mainly by this lateral plantar arch, which is actually the continuation of lateral plantar artery. That is the largest terminal branch of your posterior tibial artery. So posterior tibial artery also is used for the pulse. So behind the medial malleolus or midway between the medial malleolus and the Achilles tendon, there again we can one of the artery that you can for pulse is the posterior tibial artery. Dorsalis pedis is very important in this is the diminishing the pulse in the dorsalis pedis is a good indicator, very good indicator of this vascular disease.
Thank you, ma'am. Over to ma'am. Ma'am, can you just discuss the role of atherosclerosis in the pathogens of peripheral artery disease and its impact on the blood flow? So we all know regarding the virtuous triad how it's usually happened, the atherosclerosis. Can you just explain that, ma'am?
Atherosclerosis, there are myriad causes. There are non-modifiable risk factors and modifiable. Non-modifiable are like increasing age, gender, genetic susceptibility, and familial predisposition. And in the modifiable risk factors, we have hypertension, diabetes, hypercholesterolemia, which is one of the most important risk factor for peripheral artery occlusive disease, and smoking. Okay. So these are the contributing factors towards development of atherosclerosis. So even though it is clinically manifested at a later stage when you're a lot older, the initial events apparently start taking place from childhood in the form of fatty streaks. Then the major function, the major cause is, it is hypothesized to be response to injury hypothesis. So chronic endothelial dysfunction It activates a lot of inflammatory cells. It recruits a lot of inflammatory cells like macrophages and leukocytes into sites of atheromatous plaque formation. And of course, the main component is lipoproteins. So abnormality in your lipoprotein and lipid metabolism. So these are the major events that contribute towards your atheromatous plaque formation.
Thank you, ma'am. Again, I think you have brushed up on this, but I just wanted to a quick overview how to differentiate between an acute limb ischemia and a chronic limb ischemia. Maybe you can give few points for both of them. That will be great.
The severity of the symptoms will be more in acute, and as I already told, the main difference between an acute and chronic limb ischemia is that there will be collaterals. There will be collaterals in the chronic limb ischemia. So the symptoms as well as the duration of the symptoms will be higher in chronic limb ischemia. But for an acute limb ischemia, the patient will usually present to you with an white pulseless limb with severe pain, with severe intolerable pain. The patient will come running with an full white limb with no pulse and no sensations, as well as the patient will not be able to move. So that is when you will know that it's an acute limb ischemia. So all the 5 P's will be in severe. That is, the absolutely no pulse will be there and fully pale, and the paralysis as well as paresthesia, no sensations at all those things will be higher in acute limb ischemia. In a chronic limb ischemia, especially in a patient with no past history of intermittent claudication, that's also very important, because that tells you that the main pathology is not atherosclerosis as such, even though thrombosis can occur in atherosclerosis, but still. But in chronic limb ischemia, the patient will have a long history of intermittent claudication. The patient will be having an pain when walking, and intermittent claudication since long, and it will be continuing. And now the patient may have a rest pain if it is at the severe stages. And the pulselessness is one of the last stages. Maybe the pulse will be feeble in a patient with a chronic disease, and it may progress. The disease will keep on progressing. And paresthesia, that is altered sensations, will be there in the lower limb. And as madam also told, that atherosclerosis is a systemic disease. So you'll have to also look for other systems which are involved. For example, you'll have to ask the patient if he has any TIAs, the past history of TIAs, transient ischemic attacks, or past history of MIs if the patient has. And if the patient, very rarely, but still the patient may have mesenteric ischemia. So if the patient has postprandial angina, that is abdomen pain after having food. And if the patient has any other, for example, syncopal attacks because of carotid involvement, carotid artery involvement. So all those things you can ask in a patient with that.
Thank you.
For chronic diseases.
Thank you, Dr. Again, coming back to Manish, can you just briefly let me know when we should go for a CT angio, maybe an MR angio? You said regarding few tips, but when definitely I don't want a Doppler straight away, I think I should go for a CT angio.
Yeah.
Can we have something like that, or
So
I
suppose-
prefer to combine both?
Yeah, suppose like now we have a condition where we are dealing with a chronic case, wherein we have time in, and then we can do a Doppler, study the Doppler, and then see where the occlusion is. And many a times it so happens that these patients have a chronic disease, and they will not just have a focal segmental disease. They might have multi-segmental disease, wherein, so if you are talking about the lower limb, there will be femoral arterial disease, there will be popliteal disease, and the infrapopliteal vessels also will be equally diseased. So in those cases, sometimes will be, if it is a chronic case, still it is okay. It is just adding as a, basic point towards identifying yes, here you have a disease right from the popliteal down. And then now to subject the patient for angioplasty, now you need to go for a cross-sectional imaging like CT or MRI, MR angiogram, wherein you can really say that yes, that is the site of occlusion and there are no other sites of occlusion. You also can study the aorta, the iliacs, and then also can state whether any significant occlusion or aneurysm or any dissection is there because of which you are having some decreased flow in the peripheral arteries. So our initial investigation always would be ultrasound, which is a very good modality, but sometimes there might be array of findings in ultrasound not very conclusive. It might just point out that the occlusion or a monophasic flow is below popliteal or below femoral. So now we have to take the patient for CT angio or MR angio. Now how to decide whether to take the patient for CT angio or MR angio? That depends on several other factors. Like for example, if the patient's creatinine is borderline, then we would we'll think twice whether to subject him for CT angio. Though now I'll say few pros and cons of both. The good things about CT angio is that it is fast. It is mostly available everywhere. Then the bad things are that there is radiation involved in that, and if the vessels are heavily calcified, then the contrast which we are giving might not be well seen. In fact, it might pseudo appear as if the arteries are patent because of the calcification, but in fact it would be all occluded, and it becomes very difficult to differentiate between an occluded vessel versus a calcified vessel, especially in the infrapopliteal segment. So in those cases also MR would be better. Then another thing, as I earlier said, that if the creatinine is borderline, because when we are giving CT contrast, we'll be using huge amounts, like around 100 ml of iodinated contrast, which will ultimately lead to renal shutdown or AKI. So if to avoid that, we'll have to subject these patients then for MR angiogram. Now the bad things about MR angio is that it takes a lot of time. Yeah, and then if the patient is restless, we again would need to sedate the patient, because if there is some movement, we'll have all artifacts and no images. So it is time consuming and it is costlier, not available everywhere. And those are the problems with MRI. Another one problem which I want to highlight about MRI is that I said that CT has a lot of calcification. This is much better that we do MRI. Yes. That is true. But in certain scenarios, MR can cast a artifact with calcification. It can pseudo appear as if there is a focal occlusion, which may not be there at all. So that is a very high-end stuff, but very rare thing. But in general, if it is densely calcified, we should, and if the creatinine is high, we do MR angio or else CT angio.
Okay. Thank you. Again, coming back to madam, we were discussing regarding a lot of things according to the lower limb arteries, but we have never touched anything regarding the upper limb arteries. Always I had a doubt in my mind during my MBBS days, why the PVOD is only happening in the lower limb, why not in the upper limb? So can you just briefly let me know the arterial supply of the upper limb in contrast with what are the major differences between lower limb and upper limb arteries?
And artery is actually branching. So its caliber that branching will go, its caliber will diminish.
Okay.
And upper limb, similar pattern is there for the lower limb if you compare the arterial pattern of the upper limb. Okay. But what happened if you see the upper limb, we are seeing the anterior compartment or the flexor compartment in front, we are getting the flexor compartment posteriorly. Limb rotation happening, but the pattern is almost similar thing we can see. Here in the case of upper limb, the axillary artery is actually the continuation of subclavian artery. There we had the external iliac. And this axillary artery is again divided by the pectoralis minor into three parts, and they are giving branches in the pectoral region. And from the outer border of first rib to the lower border of teres major is the extension of axillary artery. Then it changes the name. Then from the lower border of teres major to the cubital fossa, that area you are getting the brachial artery. So similarly, in the cubital fossa, this brachial artery is dividing into the ulnar artery, radial artery. And come to lower limb, what you noticed is in the popliteal fossa, that a popliteal artery, which is the continuation of femoral artery, is dividing into the anterior tibial, posterior tibial. So the brachial artery in the upper limb, it is giving the profunda brachiae. When come to the lower limb, what you can see there, it is given off by the femoral artery, the profunda femoris, and this profunda femoris is involved in the supply of the back through the perforators, medial compartment, some part of the lateral aspect of the thigh, and the posterior compartment. Here in the upper limb again, this profunda brachiae artery that is going back and supplying the posterior compartment or the extensor compartment. Then this brachial artery at the level of neck of the radius, it divides into ulnar artery, radial artery. Ulnar artery is actually on the upper part of the forearm, it is deep, but it comes superficial, anterior to come in front of the flexor retinaculum, and it is responsible for the formation of superficial palmar arch again, and it can lateral to pisiform, you can feel that artery. Radial artery is again, it is somewhat superficially, laterally passes, and it reaches the, if you see similar to that of the anterior tibial, if you can see that it can be palpated in front of the wrist. So it is winding the lateral aspect of the wrist, the lower part of the radius, anterior part of the lower part of radius. There you can feel the pulse, radial pulse. So again the tendon, landmark, if you see your hand, that is extensor carpi radialis tendon, you can see. And between the brachioradialis and the extensor carpi radialis tendon, that is a point in front of the lower aspect of radius, anterior aspect, radial pulse we can feel. And this artery then enter into winding the wrist, it enter the anatomical snuff box. If you extend your thumb like this, we can see the snuff box. Again, the scaphoid is there present. There also we can feel this radial artery. And this radial artery, it is then continue in the palm, the deeper aspect, it continues as the deep palmar arch along with the deep branch of the ulnar artery. Ulnar artery, it lies in front of this flexor retinaculum, enter the palm, D to the palmar aponeurosis and in front of the flexor tendon. It joins with the superficial branch of radial artery, or it can join with one of the branch of radial artery like radialis indicis and princeps pollicis. And these arteries are again giving the metatarsal artery and digital arteries, and they are involved in the supply of your hand and the fingers is happening here. So this is an outline of the upper limb artery. So if you take the radial pulse here, that is between these extensor carpi radialis longus as well as the brachioradialis. In the case of lower limb, you are taking the dorsalis pedis pulse between the extensor hallucis longus and extensor digitorum longus. So medial to the extensor hallucis, lateral to the extensor hallucis longus. What you are getting, that is midway between the two malleolus, we are taking the dorsal pulse. And in the case of the diseases, this vascular diseases, one of the indication like angle brachial, index is taken. So for that auscultation of the taking pulse of upper limb artery and then comparing with that of the lower limb artery, and the index is taken. So one of the arteries most commonly is dorsalis pedis. So this is a good indicator of the vascular diseases. And in the case of foot, if you see, there are some perforators also. There is a pedal plantar loop is existing. So the perforating arteries is connecting this plantar arch as well as with that of the dorsalis pedis artery. So these are some similarities and the contrast that is existing between the upper limb and lower limb.
Thank you, ma'am. Thank you, ma'am. Again, back to ma'am. Ma'am, when we discuss regarding the pathological features of acute versus chronic limb ischemia, so what are the major changes pathologically that we are seeing in both this group of patients?
So, chronic vascular disease will show features of chronicity, as the name implies. Like I mentioned earlier, it will have a thick fibrous cap. And it will have other features like the cells that you see will mostly be chronic inflammatory cells like macrophages and predominantly T lymphocytes. And long-standing vessels that have had an atheromatous plaque will show features of calcification as well. And downstream, so it is the area downstream is not getting enough blood. So you see features of chronicity in those areas as well. You see many more stenosed arteries there, and you see the organ has shrunken or the muscles are atrophic and the nerves have hypertrophied. So features of chronicity is what you will observe in a chronic vascular disease. So acute limb ischemia is usually due to an inciting event in a plaque that was already there, like a rupture, ulceration, erosion, or hemorrhage into an existing plaque. So what you see here are features of acute events. So what you see are more acute inflammatory cells. You see neutrophils. You see the vessels there are getting damaged. The endothelium there is injured. The vessel wall is replaced by fibrinoid necrosis, and there is active neutrophilic infiltration into the vessel wall as well as to the organs that are downstream. And the organ per se, they usually become larger because there are the blood supply both to and fro have been disrupted suddenly, and the veins down there are engorged. So these are the major differences.
Thank you, ma'am. Again, coming back to Dr. Ajit, so when a patient with suspected PVOD, we have grossly covered what need to be done. What are the key investigations or key clinical investigations, that not the radiological investigation, examination, what all things we need to do? And can you just a quick overview of surgical management for these group of patients?
Okay. So it depends on if it is an acute or chronic limb ischemia. For as Madam already told, for an acute acute ischemia, it is usually an emboli or thrombosis. Thrombosis can occur in pre-existing atherosclerotic plaque, and emboli, the origin will be somewhere else. Most commonly, it will be from the heart. It can be from the the valves, infective endocarditis valves. The emboli can origin, or it can be because of atrial fibrillation from the atria or the ventricles also after the MI. So those are the causes of the acute. So you'll have to look for what's the main reason for the precipitation of the acute this thing, and investigations. If the patient there's a classification again in acute limb ischemia. If the patient is needs immediate attention, then investigations may not be required, and you may take the patient for surgery and explore the artery which is obstructed and use the Fogarty's catheter to extract. Most commonly it will be a thrombus, so to extract the thrombus or the emboli. If you have time and if the limb is not looking so ischemic, then you can do an radiological investigations, as Sir told. You can do MRI or CT to identify the vessel which is obstructed and do the further management. So for an acute, the clinical features will be obvious, and not much is required there. And as we have discussed, investigations, most of the time you will not have any time for the investigations. You'll have to take the patient up for surgery, and the main thing we'll be doing is using an Fogarty's catheter. You'll be you putting a transverse incision in the vessel which you suspect as an thrombus. You put in the Fogarty's catheter and pass it across the lesion, then pull it and do the same thing until there is actual fresh bleed from the incision which you have made. Until that, you do that, and so you can remove the thrombus in this way. So that Fogarty's catheter will be the main thing which we'll be doing in an acute limb ischemia. In a chronic limb ischemia, one of the clinical examination we already told, the history as well as the clinical examination. Muscle atrophy will be there, and loss of hair and other things we have already discussed. So the other things in investigations, clinical investigations, what you will be doing is, as Madam told, ankle brachial index will check. That is the systolic blood pressure at the ankle and divided by the brachial systolic pressure. Usually it is in the range of 0.9 to 1.4. So if it is less than 0.9, it indicates that the patient has ischemic tendencies. The ischemia is there, so you'll have to treat. And one of the other thing which you can do is other indicators for critical limb ischemia are ankle systolic pressure. Ankle systolic pressure less than 50 is critical limb ischemia. And then you can also check for transcutaneous oximetry. If it is less than 30, it is critical limb ischemia. That is very severe. And if ankle brachial index is less than 0.4, it is again critical limb ischemia. That is, the patient will need immediate surgery or some management. You can't manage the patient conservatively. All these things are indications for active management. So you can check all these things, or if you are planning for intervention, then you can do MRI or CT as Sir told, because both are invasive and a lot of contrast is being given, so morbidities are high. So unless and until you are planning to intervene, you don't have to go for higher imaging there. And the most of the treatment, if the patient does not have any critical limb ischemia, that is the limb is not threatened, then you can try conservative management. Even though pentoxifylline and silastazole can be used for vasodilatation and other things, but nowadays those are not usually used, because the exercise treatment, that is supervised exercise treatment, is the most commonly used nowadays. At least minimum of 2 hours of exercise for 3 months, at least minimum of 3 months. Over 3 months the patient has to do under supervision by a physiotherapist. That helps better than any of the medications which we try. But the medications which we have to give is for atherosclerosis, to control atherosclerosis. So everything like an antiplatelet drug, ecosprin, or a clopidogrel you can clopidogrel you can use, and then you have to give the patient statins. Obviously, even if the patient has normal lipid profile, the statins will still help in controlling the atherosclerosis. So in a patient with peripheral chronic ischemia, always start him on statins as well as ecosprin, and exercise therapy, supervised exercise therapy, that is very important. And then if you think it is helpful, you can use pentoxifylline or cilostazol also for as a backup. Then if the patient has critical limb ischemia, then we'll have to go for active management. So that can be divided into endovascular treatment, then bypass surgeries. So endovascular treatment, you can use similar to what we do in cardiac patient, MI patients. We can use angioplasty. Angioplasty ballooning can be done, and even stents can be used. Metallic stents, self-expanding metallic stents, all can be used for similar to what we do in an MI patient. Here also we can do that. If that fails, we can try for, if the vessel, the larger vessels are involved, then bypass techniques are better. And especially in atherosclerotic patients, because it's the aortic and aorta iliac which is mostly involved, their bypass is more easier. We can use an aortofemoral bypass can be done if the block is at the femoral level, or if the block is at the popliteal level, you can use a femoropopliteal bypass. For below the inguinal ligament, for bypass, you can use PTFE, or better would be an venous graft, great saphenous vein grafts. Above the inguinal ligament, Dacron can be used. Dacron would be a good material to use for bypass surgery. And depending on where the obstruction is, you can use bypass. And the general principle is above the inguinal ligament, you can use Dacron grafts, and below you can use PTFE or venous bypass graft.
Thank you. Again, Manish, coming back to you. So we had a brief discussion regarding endovascular therapy. So what are the things that offer by an interventional radiologist in case of a PVOD? So I have heard patients who had a non-yielding ulcer, they will come to the radiologist first, and they first wanted to open up the vessel, then to see the debridement, how the flow improves. So what are the things that you offer as an intervention?
Yes, I mean, now, and depending upon the, now again, clinical symptoms, how he has presented, if it is acute or chronic. If it is acute, we do the Doppler, we see for something called thumping pattern. And what happens is the vessel there at the site of occlusion, just proximal to occlusion, will be dilated, and thumping pattern would be seen in Doppler, and distal to that there won't be any vascularity. So we do the CT or MR angio and confirm the finding, and then we take him for either a mechanical thrombectomy, which is now available with the angiojet devices like angiojet and all, or else we do a thrombolysis for 24 to 48 hours and then see how is the response. If still it is not responding, we'll subject him to surgical exploration, as he said, using a Fogarty and then extracting that. Now coming to chronic limb ischemias, with especially those with critical limb ischemia, on them we will again subject them to CT or MRI if there is a good distal runoff. So suppose we have a plaque in the superficial femoral artery, and around at the adductor hiatus it is occluded for maybe around 4 to 5 centimeters, and distally again the popliteal is patent. Now this happens through the collaterals. So these are the sort of patients which will benefit with angioplasty. Or else, let's say there is another patient who has got a short segment occlusion or a long segment occlusion in the femoral artery, plus he's got further occlusions in the popliteal as well as in the infrapopliteal segment. So each of these we can puncture either retrogradely or antegradally and get into the femoral arteries, go across that occluded segment using a small wire, and then once we are across, we can then take in a balloon through that and then angioplasty it. So depending upon the size of the vessel, the balloon size also would vary. For example, if it is a iliac, it would be around 7-8 mm. If it is femoral artery, it will be 5 to 6 mm. If it is popliteal artery, it will be around 4 mm. And then infrapopliteal will be around 2.5-3 mm, like that. Once we have plastied, we will see if the vessel is remaining open or not. If it is densely calcified, or if there is a focal dissection there, those are the times when we plan to stent that segment. And there are different types of stents available, as he said. SEMs are there, means self-expandable metallic stents are there. Special vascular stents are there which can resist deformation, especially when it is across the femoral artery where the hip joint is there, or across the popliteal artery. So these are things.
Ma'am, again, one of the important questions that an MBBS student should know regarding this area, PVOD related, and I know anatomy, everything is important. So specifically, anything that they should know, can you just let us know?
Before that, I want to tell regarding the front of forearm. I forgot that.
Sure, ma'am. Sure, ma'am.
The thing is that here the ulnar artery is giving one of the branch common interosseous artery, and it is dividing into anterior interosseous artery, which is supplying the anterior compartment, and other one is posterior interosseous artery. Again, similar to that of your lower limb, it is passing to the posterior compartment and supplying the posterior compartment or the extensor compartment. So that is, if you come to the lower limb, what you can again see, there it is the popliteal artery dividing to anterior posterior, and is coming to the anterior aspect of interosseous membrane, posterior is coming to the posterior aspect of interosseous membrane. Here regarding the first graduate MBBS students, why we are studying this artery is one most important one in the upper limb is the brachial artery. So we are taking the brachial artery pulse. So one of the landmark you can take in the cubital fossa is the tendon of biceps. So medial to that, 2 centimeter medial to that, we can palpate the brachial artery. So they have to know, as question is there, palpation of brachial artery is one of the question in the practical. Other one is coming the radial artery again. So radial artery also we can palpate, that is lateral to the flexor carpi radialis or anterior aspect of the wrist, that is the radius, lower part of the radius. We can palpate this radial artery. That is another question. Radial pulse is the question in the exam for palpation. And coming to the lower limb, the other one is femoral pulse is there, again between anterospheric spine and the pubic tubercle mid-inguinal point. They can palpate the femoral artery, and femoral artery is important in catheterization. It is important to take the femoral pulse, and also for the embalming purpose also this artery is used, and it is more superficial, so that's why the catheterization is very easy to approach in the femoral triangle. And other artery is, they have the dorsalis pedis, is the other palpation, very important for them for the exam purpose, because it is midway between the two malleolus. It is also superficial, easy to get the pulse and all. So that is important for them, which is lateral to the tendon of the extensor hallucis longus. So they can easily, that's one of the questions they have. Other in their syllabus, it is also given the posterior tibial pulse, that is behind the medial malleolus. They can palpate it. So these are the questions they are getting from practical point of view in the syllabus. And other thing is, generally it is given the distribution, branches and the course of all these arteries are there, especially brachial, femoral, all these arteries are there.
Okay, thank you, ma'am.
In fact, one of the clinical implications which might be interesting for them is that just see, as madam has said, where all it is superficial, it is exactly where we are puncturing there. So it is not a big deal for us to puncture now the deep vessels, because now we are puncturing with ultrasound this thing. But to achieve hemostasis, we have to puncture only where it is superficial. Like the where we can compress. Yes, so that they should be knowing. That is one of the clinical importance.
Yes. Thank you, ma'am. Again, coming to ma'am, again in pathology, I know atherosclerosis, definitely it's a question. So anything specific that they should and UG should know, can you just elaborate, ma'am?
The most important would be pathogenesis of atherosclerosis per se, because it's a very evolving field. There are a lot of genes that are getting implicated. So at least the basic mechanism, the response to injury hypothesis, the endothelial dysfunction, how atheromatous plaques are formed, and how to identify one when you see it. So the basic pathologic features of how to identify a stenosed artery, and what are the features that you favor for acute versus chronic, what are the inflammatory cells that you're likely to see, and what are the features of chronicity, and pathogenesis of atherosclerosis. So these are the two most important things that...
Slides, ma'am, usually these all will be kept.
Yes.
Atherosclerotic, chronic vessel will be usually kept a normal and then atherosclerosis.
Yes.
Okay. Yes. Thank you, ma'am. Again, Dr. Ajit, can you briefly, I know it's an important thing for general surgery perspective.
Generally nowadays the questions are split and they're giving clinical scenarios, so you should be knowing about the different clinical scenarios in different peripheral vascular obstructive disease. As I already told, one of those things is atherosclerosis. If a patient, if a case scenario is there where there is a lot of other systemic diseases, that is the patient is having syncopal attacks as well as the past history of MI is there, stroke is there, and then the patient is having an lower peripheral vascular obstructive disease, then the management will be little different, mainly because the bypass should the vessels which are involved will be the aortic and aortoiliac. And then if the patient is an younger patient with a chronic smoker with no other systemic disease, only the lower limb is involved, then again it is an TAO, that is thromboangiitis obliterans and Berger's disease. So, and in diabetic patients with an non-healing ulcer, only one distal pulse, that is a dorsalis pedis, is absent, but everything else is normal. There the treatment is little different because bypass can't be done, nor intravascular diseases, intravascular interventions can also not be done, because the disease is in the smaller vessels. So control of diabetes and other things will become more important. So depending on the case scenario what they give, you'll have to alter your management and your investigations according to that, because nowadays it's not generally general questions like peripheral vascular obstructive disease and causes. They are not asking those things. They are giving clinical scenarios. All the main questions are clinical scenarios with split questions, that is what are the causes and how you manage this case, and so you'll have to know about the different clinical scenarios there. And then again, short notes, the ankle brachial index can be asked for short answers or short notes, and critical limb ischemia can be asked, and amputations, as well as when will you do an amputation, and the management as such of peripheral vascular obstructive disease, and what we discussed, the difference between an acute and chronic limb ischemia, clinical differences between those things. Those are all the questions that can be asked, and it's a very important chapter. Vascular, either an venous or an arterial, one question will be there for main question there.
Thank you. Again, Manish, UGs, what they can expect from, I know radiology, theoretically and practically, it's not given much important, but nowadays because of the endovascular therapies and all, definitely the recent advances, at least they should be doing something.
Yes, in fact, more than the exam point of view, rather when they come into the clinical practice, it becomes more useful. At least they should be knowing when to subject a patient to a CT, what are the negatives of CT, like ionizing radiation is there. If it is a pregnant lady, you should not be. If it is a child, you should be careful. Plus, if the patient has got CKD, then we should not be subjecting for CT contrast. Wherein we have alternatives like MR, but MR was also not very straightforward. Some artifacts would be there. So they should not be knowing in depth of this, but they should be generally knowing that okay, these are the advantages of CT, these are the advantages of MRI, and when these should not be done. For example, a patient with the implant is there, or a cardiac pacemaker is there. So those patients should not be subjected to MRI. So these are very basic things now, which I think our students should know.
Thank you, Manish. On behalf of Amrita School of Medicine, I thank each one of you who have gathered here and you have shared the experience. And it was one of the wonderful discussions that I had chaired, and it was nice talking to each one of you. And thank you all. Thank you.